Hello students. Welcome to Concepts of Care for Patients with Musculoskeletal Trauma, Part 3. So, as I told you before, this is a very long chapter, but we are describing all the disorders, the conditions, the fractures on detail, and we need to know this, okay? Um, Let's start with fractures of the chest and pelvis. Chest trauma may cause fractures of the ribs or sternum, right? The major concern with rib and sternal fractures is the potential for puncture of the lungs, heart, or arteries by bone fragments or ends. So this is important if we know our anatomy and physiology, right? we can um, we can think about what structures around the fracture or the trauma are at risk, right? In this case, the lungs, heart, and arteries. So we need to assess airway, breathing, and circulation status first for any patient having chest trauma. For example, if it's a pelvic fracture or a hip fracture, we need to assess the femoral artery, right? Okay, so fractures of the lower ribs may damage underlying organs such as the liver, spleen, or kidneys. As I was telling you, we need to know the anatomy. These fractures tend to heal on their own without surgical intervention. The ones that I just mentioned, fractures of the lower ribs that may damage the liver, spleen, or kidneys. So high risk for pneumonia. Um, Patients are often uncomfortable during the healing process and require analgesia. Okay. They also have a high risk for pneumonia because of shallow breathing caused by pain and inspiration. Encourage them to breathe normally if possible and ensure that their pain is well managed. Okay. So that's good to know. This is NCLEX alert. So you may see a question about a patient having a fracture, right, in the rib, and what is your priority as nursing intervention, right? And you have to as you need to assess for ABCs and then encourage them to breathe normally if possible to ensure that their pain is well managed, right? Because the pelvis is very vascular and is close to major organs and blood vessels, associated internal damage is the major focus in fracture management. After head injuries, pelvic fractures are the second most common cause of death from trauma. Let me repeat that. After head injuries, pelvic fractures are the second most common cause of death from trauma. In young adults, pelvic fractures typically result from motor vehicle crashes or falls from buildings. Young adults. Falls are the most common cause in older adults. So in young adults is a result from motor vehicle crashes or falls, and in older adults, falls is the most common cause. The major concern related to pelvic injury is venous, oozing, or arterial bleeding, as I was telling you, right? Loss of blood volume leads to hypovolemic shock. That's good to know. Safety, 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 and I will say assessment, assessment, assessment. Action alert: assess for internal abdominal trauma by checking for blood in the urine and stool and by monitoring the abdomen for the development of rigidity or swelling, right? Also, a system that is particularly useful divides fractures of the pelvis into two broad categories. So they divide the fractures into non-weight bearing fractures and weight bearing fractures. When a non-weight bearing part of the pelvis is fractured, for example, the iliac crest treatment can be as minimal as bed rest on a firm mattress or bed board. This type of fracture can be quite painful, and the patient may need stool softeners to facilitate bowel movement, of course, because of hesitancy to move. Well-stabilized fractures usually heal in 2 months. A weight-bearing fracture, such as multiple fractures of the pelvic ring, creating instability, or a fractured acetabulum, necessitates external fixation or open reduction, internal fixation, or maybe both. Okay, so let's continue. Let's go to, right now, let's go to analyze compression fractures of the spine. So most vertebral fractures are caused by osteoporosis or metastatic bone cancer. What happens is the trabecular or cancellous bone within the vertebra becomes weakened and causes the vertebral body to collapse. The patient has severe pain, especially when moving, deformity, kyphosis, and possible neurologic compromise. So non-surgical management includes bed rest. We're talking about compression fracture of the spine, analgesics, nerve blocks, and physical therapy to maintain muscle strength. Vertebral compression fractures that remain painful and impair mobility may be treated with vertebroplasty or kyphoplasty. So we are going to watch the video, what is a vertebroplasty or kyphoplasty, which I really believe it's a great procedure and you're going to see the benefits. Let's watch this video.
Most people above the age of 60 to 65 years suffer from back pain. Osteoporosis frequently causes vertebral compression that further results the vertebral body to collapse, resulting into a fracture. Patients suffering from this lose bone mass over time. As a result, the spine becomes weak and is no longer able to take the body weight. Hence, patients start developing severe back pain and a progressive loss of height is noticed. Kyphoplasty and vertebroplasty are the most effective, minimally invasive, pain-relieving treatments for the elderly patients. Kyphoplasty is a procedure in which the compression fracture of the spine is rectified. Typically, a special instrument with a deflated balloon is inserted into the fractured vertebra and is carefully inflated to create a cavity within the fracture. Once the space is created, the balloon is gently removed. Bone cement is then injected into the void space that hardens quickly, thus stabilizing, strengthening, and helping to reshape the vertebra. Vertebroplasty is a minimally invasive surgical procedure. In this, 2 hollow needles are put through the pedicles into the fractured vertebral body. Through special delivery mechanism, bone cement is injected. The bone cement quickly hardens, thus stabilizing the fracture, offering structural support to the vertebra. Both kyphoplasty and vertebroplasty relieve pain and give stability to the spine. These procedures help stabilize vertebral compression fractures and angle of the affected vertebrae, thus restoring it to a more normal height and shape.
That's excellent. These are excellent procedures, really. Very good. Okay, so what happened is that the patient is going to get IV ketorolac, as we learn in other procedures, and they are going to, the procedure is in the ambulatory care setting and return home after 2 to 4 hours, or be admitted to the hospital for an overnight stay. Before discharge, teach the patient to report any signs and symptoms or infection from punctured sites. Remind the patient to avoid a soaking bath for 1 week. Use analgesics as needed and resume activity slowly. Okay. I wanted to mention that ketorolac is known as Toradol. It's an NSAID that is similar to the over-the-counter treatments like ibuprofen, Advil, Motrin, and naproxen, but it's more powerful and requires a prescription. Yes, but also I want to mention that please do your assessment and ask the patient if the patient is having any ulcers, stomach ulcers, or any kind of bleeding problems, okay? Because ketorolac is very strong. Okay, best practice for patient safety and quality care, nursing care for patients having vertebroplasty or kyphoplasty. Check the patient's coagulation, laboratory test results, platelet count should be more than 100,000. Even though platelets normally is 150 to 350 or 400, depending on the laboratory, minimum should be more than 100,000. Make sure that all anticoagulant drugs were discontinued. Assess and document the patient's neurologic status, especially extremity movement and sensation. Assess the patient ability to lie prone for at least 1 hour, and establish an IV line for a size suitable for surgery, and take vital signs. Provide post-procedure care, include place the patient in a flat supine position for 1 to 2 hours, frequent neurologic assessment, apply ice pack to the puncture, assess the patient pain level, monitor for complications such as bleeding at the puncture site or shortness of breath, and assist the patient with ambulation. Before discharge, avoid driving. Monitor the puncture site for signs of infection. Keep the dressing dry. Begin usual activities, including walking, the next day, and slowly increase the activity level over the next few days. Let's move to perfusion concept exemplar amputation. So amputation may be elective or traumatic. Most amputations are elective and are related to complications of peripheral artery disease that result in decreased perfusion to distal areas of the lower extremity. And traumatic amputations most often result from accidents or war. So levels of amputation, you have elective lower extremity. Amputations are performed much more frequently than upper extremity amputations. Severe types of lower extremity amputations may be performed several times, right? The loss of any or all of the small toes presents a minor disability. Loss of the great toe is significant because it affects the balance, gait, and push-off ability during walking. So right now, the book is starting to describe different levels of amputation and by location, right? We have sign amputation. Most of the foot is removed. This is a type of amputation, but the ankle remains. The advantage of this surgery over traditional amputations below the knee is that weight bearing can occur without the use of a prosthesis and with reduced pain. So let's watch a video about the sign amputation. Okay. So you can see the whole foot was removed, but you can see the ankle is supporting weight bearing. Okay. So most of the foot is removed, but this ankle remains. An intense effort is made to preserve knee joints. Now we are moving to another type. An intense effort is made to preserve knee joints with below the knee amputation. When the cause for the amputation extends beyond the knee, above knee or higher amputations are performed. Let me repeat. when the cause for the amputation extends beyond the knee, above the knee or higher amputations are performed. Hip disarticulation or removal of the hip joint and hemipelvectomy, removal of half of the pelvis with the leg, are more common in younger patients than in older ones who cannot easily handle the cumbersome prostheses required for ambulation. The higher the level of amputation, the more energy is required for mobility. That's good to know. The higher the level of amputation, the more energy is required for mobility. These higher level procedures are sometimes done for cancer of the bone, osteomyelitis, or trauma as a last result. Okay, very good. So let's move forward to complications of amputation. The most common complications are hemorrhage leading to hypovolemic shock, of course, infection, yes, phantom limb pain, neuroma, and flexion contractures. So let's go and get deep into these concepts. Persistent pain is a frequent complication of amputation. When it persists and is unpleasant or painful, it is referred to as phantom limb pain. Phantom limb pain, I'm going to refer to this as PLP, is more common in patients who had chronic limb pain before the surgery and less common in those who have traumatic amputation. The patient reports pain in the removed body part shortly after surgery, usually after an above the knee amputation. Phantom limb pain, PLP, is more frequently usually after an above the knee amputation, aka neuroma, a sensitive tumor consisting of damaged nerve cells forms most often in amputation of the upper extremity but can occur anywhere. Neuroma is more common in amputation of the upper extremity. Surgery to remove the neuroma may be performed, but it often regrows and is more painful than before the surgery. Oh, wow. Non-surgical modalities include peripheral nerve blocks, steroid injections, and cognitive therapies such as hypnosis. Flexion contractures of the hip or knee are most frequently seen in patients with amputation of the lower extremity. This complication must be avoided so that the patient can ambulate with a prosthetic device. Etiology and genetic risk: diabetes mellitus, diabetes, is typically the underlying cause of peripheral arterial disease, which leads to lower extremity amputation for many patients. Diabetes, peripheral arterial disease, lower amputation of the lower extremity. Amputation should be considered only after other interventions have failed to restore circulation to the lower extremity. That's why the amputation takes place, because there is not enough circulation or minimal circulation. And sometimes the tissues get necrotic, right? Sometimes referred to as limb salvage procedures. So interventions have failed to restore circulation. So this amputation is going to happen if all the other procedures are being done, techniques to save the limb, including the limb salvage procedures, or percutaneous transluminal angioplasty. Trauma to a limb is the second leading cause of amputation. Trauma to a limb is the second leading cause of amputation and is the primary cause of upper extremity amputation, right? So diabetes is typically the underlying cause of peripheral arterial disease, which leads to lower extremity amputation. And trauma of the limb is the second leading cause of amputation and is the primary cause of upper extremity amputation. Okay, so incidence and prevalence: over 2 million people live with amputations in the United States. People of color are most likely to have limb loss due to diabetes mellitus and peripheral artery disease. Elective lower extremity amputations. Research on the incidence of elective lower extremity amputations demonstrate the following health equity issues. 1. Black individuals are less likely than whites to undergo limb salvage procedures, like we mentioned before. What are the names of the limb salvage procedures? Percutaneous transluminal angioplastic. What they are doing is they are inserting a cannula, and through the cannula they open where they open the the artery, right? They open the artery that sometimes they're having a plaque or for some reason is narrow. They open the artery either with a balloon or with stent, so the circulation is restored. And not everybody is having the possibility to have this procedure. Um, So black individuals are less likely than whites to undergo limb salvage procedures. Therefore, black individuals, especially men, are twice as likely to have a lower extremity amputation due to diabetes mellitus as a result of peripheral arterial disease. Now, Hispanics are 30% more likely than whites to have a major lower extremity amputation related to diabetic foot infection. Indigenous people are 70% more likely than insured non-indigenous people to have a lower extremity amputation. So there you go, you have three populations right there. Low household income and lack of health care access are largely responsible for these health inequities. Now let's talk about the veteran health. Traumatic amputations has increased during recent wars as a result of hidden landmines, bombs, and motor vehicle crashes, especially in Iraq and Afghanistan. Additionally, many veteran amputees have comorbid physical and mental health problems, including traumatic brain injury and post-traumatic stress disorders. Ay, our veterans. I feel sorry for them. Okay, health promotion, disease prevention. Typical patients undergoing elective amputation at middle age or older people of color who have diabetes and a length history of smoking. So there you go. You have two things that are preventable, right? Those are preventable. Diabetes can be treatable, preventable, if you get the right nutrition and you follow lifestyle changes and smoking. These patients have not cared for their feet properly due to lack of knowledge, which results in non-healing, infected foot ulcer, and possible gangrene, which is necrotic, right? The second largest group, young men involved in motorcycle or other vehicle crashes who are injured by industrial equipment or who have been in combat or accidents in war. Okay, so physical assessment, monitor neurovascular status in the affected extremity. I don't remember how many times, I cannot remember how many times we mentioned the neurovascular status assessment. Psychosocial assessment, evaluate their psychological preparation for a planned amputation and expect them to go through the grieving process. Sometimes this evaluation is not accurate because if the patient does not open his or her heart to this evaluation, really you cannot be prepared or plan for care post procedure. Determine the patient's willingness and motivation to withstand prolonged rehabilitation after the amputation. Yes. So we need somebody to connect with the patients in order to get an accurate information. Let's go back to veteran health. Um, Psychological impact of amputation. The young military service member may be bitter, hostile, or depressed. The young military, of course, if experiencing one or more traumatic amputations while being deployed. This is very sad. Culture and spirituality, family response to amputation. Assess the family's reaction to the surgery or trauma. The family response usually correlates directly with the patient's progress during recovery and rehabilitation and the patient's values and belief. Is the type of energy of the caregiver, the family member that is going to help the patient improve in their condition. Okay, that's why it's very important to assess the family, the surrounding of the patient. Some groups, Jewish, require that the amputated body part be stored for later burial with the rest of the body or buried immediately. And that's also interesting to know, to be familiarized with all these cultural practices. Diagnostic assessment. One procedure is measurement of segmental limb blood pressure, which can also be used by the nurse at the bedside. Ankle brachial index is calculated by dividing ankle systolic pressure by brachial systolic pressure. A normal ABI is 0.9 or higher, and I'm sure most of you got this test done whenever you go to get your annual examination in the PCP. Doppler ultrasonography or laser Doppler flowmetry and transcutaneous oxygen pressure also are non-invasive tests. The ultrasonography and laser Doppler measure the speed of blood flow in the lip, and the transcutaneous oxygen pressure measures oxygen pressure to indicate blood flow in the limb, and it has proven reliable for predicting healing. So what are we going to address? Potential for decreased tissue perfusion, acute or persistent pain, decreased mobility due to pain, and decreased self-esteem due to one or more ADL deficits, distorted self-concept and body image, and or lack of support system. Monitor for decreased tissue perfusion. What are we going to do? The interventions. A traumatic amputation requires rapid emergency care to possibly save the severe body part for reattachment to promote perfusion and prevent hemorrhage. So emergency care, traumatic versus elective amputation. Notice the difference. For a person who has a traumatic amputation, assess the patient for airway. Apply direct pressure with layers of dry gauze or other cloth on the side of the problem. Elevate the extremity above the patient's heart to decrease the bleeding. So those are steps, right? The fingers are the most likely part to be amputated and replanted. So the current recommendation for pre-hospital care is to wrap the completely severed finger in dry, sterile gauze, if available, or a clean cloth. Put the finger in a watertight, sealed plastic bag. Place the bag in ice water, never directly on ice. Add 1 part of ice and 3 parts of water. Avoid contact between the finger and the water to prevent tissue damage. For patients with planned elective surgical amputation, the nurse's primary focus is to monitor for signs indicating that there is sufficient tissue perfusion and no hemorrhage. The skin flap at the end of the residual remaining limb should be pink in a light-skinned person, and it should not be discolored lighter or darker than other usual skin pigmentations in a dark skinned patient. The area should be warm but not hot. Assess the closest proximal pulse for presence and strength and compare it with that in the other extremity. Okay. So critical rescue, if the patient has a decreased tissue perfusion, notify the surgeon or the rapid response team immediately to communicate your assessment finding. If the patient blood pressure drops and the pulse increases, suspect cover hidden bleeding, right? So the pulse increases means tachycardia and the blood pressure drops, you suspect bleeding. If bleeding occurs, apply direct pressure and notify the rapid response team or primary healthcare provider immediately. So how are we going to manage acute or persistent pain? We need so pain as a result of either traumatic or surgical elective amputation. We need to consider if it's a pain from traumatic or surgical amputation, or is a phantom limb pain, right? We need to know which type it is. Action alert. If the patient reports the phantom limb pain, recognize that the pain is real. So that's very important. You always recognize the phantom limb pain as real and should be managed promptly and completely. It is not therapeutic to remind the patient that the limb cannot be hurting because it is missing, and it's not therapeutic to do so. Opioid analgesics are not as effective for PLP, phantom limb pain, as they are for residual limb pain. Let me repeat. Opioid analgesics are not as effective for phantom limb pain as they are for residual limb pain. So you don't request doctor to prescribe that. IV infusions of calcitonin during the week after amputation can reduce phantom limb pain. Infusions of calcitonin, those can reduce phantom limb pain. Also, beta-blocking agents such as propranolol are used for constant dull burning pain. Antiepileptics such as pregabalin and gabapentin may be used for nail-like or sharp burning neuropathic pain. That's why you need to assess your pain in terms of the characteristics to see what medication is appropriate. Antispasmodics such as baclofen may be prescribed for muscle spasm or cramping. And physical therapies often use massage, heat, transcutaneous electrical nerve stimulation, mirror therapy, and ultrasound therapy for pain control. Let's move to promoting mobility. What are we going to do? Collaborate with the physical and or occupational therapists to begin exercises as soon as possible after surgery. If the amputation is planned, the therapist may work with the patient before the surgery to start muscle strengthening exercises and evaluate the need for ambulatory aids such as crutches. Okay, so that's before the surgery. For patients with above or below the knee amputations, teach range of motion exercises for prevention of flexion contractures that we studied before, a few minutes before, particularly of the hip and knee. And then a firm mattress is essential for preventing contractures with a leg amputation. Assist the patient into a prone position every 3 to 4 hours for 20 to 30-minute period if tolerated and not contraindicated. Okay, remember it was a leg amputation. This position may be uncomfortable initially, but it helps prevent hip flexion contractures. Instruct the patient to pull the residual limb close to the other leg and contract the gluteal muscles of the buttocks for muscle straightening. Here is another box with care of patients who have an amputation. For example, an above the knee amputation has the potential for more or postoperative complication than does a partial foot amputation. So above the knee has more potential for more postoperative complication than does a partial foot amputation. Regardless of where the amputation occurs, collaborate with the rehabilitation therapist to improve ambulation and or enable the patient to be independent in ALDL. So we continue with above and below the knee amputation. Teach the patient how to push the residual limb down toward the bed while reporting it on a soft pillow at first. While supporting it, on a soft pillow at first. Then instruct the patient to continue this activity using a firmer pillow and then progress to a harder surface. This activity helps prepare the residual limb for prosthesis and reduces the incidence of phantom limb pain and sensation. So this preparation is little by little, right? Toward prosthesis. Before an elective amputation, the patient often sees a certified prosthetic orthotist so that planning can begin for the postoperative period. And the following paragraphs has a lot of it has a lot of details about prosthesis type, design, material listed below. All of them depends on the patient type and amputation, etc., etc. So I'm gonna skip it. Promoting self-esteem. If possible, arrange for the patient to meet with a rehabilitated active amputee who is about the same age as the patient. And this intervention is crucial. I hope everybody that went through an amputation has this opportunity to meet with a rehabilitated active amputee, a person in the same category with the same problem, or rehabilitated with a strong mental status. This is a nice support. Assess the patient verbal and nonverbal references to the affected area. Also assess the patient's feelings. With advancements in prosthesis and surgical techniques, many patients can return to their jobs and other activities. That's true. If a job or career change is necessary, collaborate with a social worker or vocational rehabilitation specialist to evaluate the patient's skills. Professional assistance from a sex therapist, also intimacy coach or psychologist may be needed. It's a whole new world. So we have another NCLEX question. The nurse is interviewing a client who is planning to have an elective below the knee amputation for a non-healing diabetic ulcer and gangrene. My God. The client expresses feeling sad and useless without both legs. What would be the nurse's best response? And the answer is, can you tell me more about your feelings of sadness and uselessness? These answers are in your electronic version. If you go to student resources and you select the chapter under answer key, you can find these answers. Care coordination and transition management. The patient is discharged directly to home or to a skilled facility or rehabilitation facility, depending on the extent of the amputation. Where rehabilitation is not feasible, as in older adult with dementia or other debilitating impairment, the patient may be discharged to a long-term care facility. Yeah, it's the best choice. Home care management, enough room. They need to check if there is enough room to use a wheelchair. be able to use toileting facilities, have access to area necessary for self-management, such as kitchen. Structural home modifications may be needed. Self-management education. After the sutures or staples are removed, the patient begins residual limb care. Let me get a sip of water. Thank you. The limb should be rewrapped several times a day with an elastic bandage applied in a figure 8 manner. This is good to know, nurses, how you are going to educate the patient or provide proper care if you are home health nurse. Okay, that's good to know. For many patients, a shrinker stocking or sock is easier to apply. After the limb is healed, it is cleaned each day with the rest of the body during bathing with soap and water. So, home health care for patients with lower extremity amputation in the home. You need to assess for adequate circulation, infection, healing, flexion, contracture, dressing, elastic wrap, right? Assess the patient ability to perform LDLs in the home. Okay. So, action alert. Collaborate with the prosthetic to teach the patient about care of the prosthesis to ensure its reliability and proper function. That's very important. These devices are custom made, taking into account the patient's level of amputation, lifestyle, and occupation. This is great. This is great. They are going to consider your lifestyle and occupation. I hope some countries in Latin America will have this type of devices. Proper teaching regarding correct cleansing of the socket and inserts, wearing of the correct liners, and assessment of footwear is essential before discharge. So you need to get a return demonstration of how to use this. Healthcare resources. There is a variety here that you can share with the patient. Um, the same thing for the veteran health. And here are examples of military and commonly resources for veterans with amputation in the United States. Look at this list. Military One Source, Wounded Warrior Project. Excellent, excellent, excellent. So we're gonna stop here, and when we come back, we are gonna check for we're gonna study carpal tunnel syndrome. We're almost done with this long chapter, but as you see, there are many varieties. There's a huge variety of fractures, traumas that we need to analyze. Okay, so stay tuned.